afternoon. My name is Megan Ames, and I'm a representative of the Maryland Department of Health and Mental Hygiene. I'd like to welcome you to the 5th Breastfeeding Educational Webinar for Healthcare Providers. Today, you'll hear the presentation, The Immunology of Human Milk. This program is part of the Maryland Department of Health and Mental Hygiene Hospital Breastfeeding Policies Physician Webinar Series. After completing this presentation and successfully completing a post-test, physicians will receive 1 hour of continuing medical education. This CME will be available through June 2019. DHMH thanks LifeBridge Health and Dr. Dana Silver for partnering with us to make this possible. Per DHMH policy, we remind our listening audience of the recommended steps to reduce contracting the Zika virus, which can cause serious birth defects. Citizens are advised to avoid mosquito bites, use insect repellent, and empty containers of standing water. This slide pictures the species of mosquito that spreads the Zika virus, and here are websites that you can use to find more information. I now want to move on to our presentation. Your speaker today is Dr. Michael Young. Dr. Young is currently an associate professor in the Department of Pediatrics and Child Health at Howard University College of Medicine. She is the director of the NICU and Newborn Services at Howard University Hospital. She also serves as the medical director of BLESS, Breastfeeding Lactation Education Support Services Initiative at Howard University Hospital. She's a graduate of Howard University College of Medicine, class of 1979. Dr. Young completed a rotating internship in medicine and pediatrics at Grady Memorial and Emory Hospital in Atlanta, Georgia, followed by a pediatric residency at Howard University Hospital and a fellowship in neonatal perinatal medicine at Georgetown University Hospital. 18 years of her clinical and academic practice was at DC General Hospital, where she was the director of the NICU for the last 5 years prior to the closure of that hospital in July 2001. Dr. Young has several publications and presentations over a range of topics governing infant care. Her research interests are in developmental outcomes of the ELBW, HIV perinatal transmission, and in breastfeeding education for professionals and parents. Dr. Young had just completed her fellowship in neonatology at the time of the birth of her first child. She recalls how poorly educated she was about breastfeeding and the benefits of human milk. This experience placed her on a lifelong quest to improve breastfeeding education for medical professionals and patients' families. Dr. Young speaks locally and nationally about the benefits of breast milk and breastfeeding for the human infant. She is a member of the Academy of Breastfeeding Medicine, a member of the Academy of Breastfeeding Medicine Protocol Committee, member of the Baby Friendly USA NICU Task Force, a member of the Section on Breastfeeding in the American Academy of Pediatrics, one of the breastfeeding coordinators for the DC chapter of the American Academy of Pediatrics, a member of the board of directors for DC Breastfeeding Coalition, and a member of the advisory board on Health Connect 1, as well as a member of the board of directors for ROSE, which is Reaching Our Sisters Everywhere Incorporated. I look forward to hearing Dr. Young's presentation.
Good afternoon. I'm glad to join you all this afternoon to talk about the immunology of human milk. I have no disclosures. The slide is not advancing for me. There we go. No disclosures to make, no relevant financial relationships, and I'm not going to discuss any unapproved investigative use of a commercial product or device. It is my hope that the student, I say student because those of us physicians know that we are forever students if we plan to maintain and stay up with the practice of medicine. So it is my hope that the student will be able to list at least 5 immunological components of human milk and their roles in immune protection, express the reasons for the policy of the American Academy of Pediatrics regarding breastfeeding and preterm infants that weigh less than 1,500 grams at birth, to recognize illnesses that can be ameliorated by breastfeeding, to identify absolute contraindications to breastfeeding, and last but certainly not least, explain general nutritional and immunological benefits of breastfeeding to the health of the infant. So that we're all on the same page, I start with breastfeeding. Its definition: to feed a baby milk from the breast, to suckle or nurse. Now, this is the optimal way we like for infants to be fed, because it allows direct contact of mother and baby, which informs the maternal immune system of the infant's environment and helps to update that maternal system to be able to help protect the infant. Now, we do recognize, of course, that all babies are not necessarily able to suckle or feed, sometimes due to prematurity, other times due to orofacial challenges. But even those babies should get their own mother's milk. The immune system of the human being is able to survey a situation even without tasting, testing, touching, and recognize that there are antigens in the environment. We know that this informs maternal systems because we have mothers who walk into our units, our NICUs, every day. They don't dust, they don't wipe, they don't do any of those kind of things, and yet they know the nosocomial organisms that their neonates are presented with. And so we see then that mothers who provide their own milk for their own preterms, we see less nosocomial infections in infants who are in neonatal intensive care units receiving their own mother's milk. That's just the beginning of the great things that immunologically that human milk holds. This slide before you just gives you the usual process. The infant suckles at the breast. It stimulates nerve endings in the mother's nipple areola. It sends out signals to her hypothalamus and pituitary, where we get release of oxytocin and prolactin. And those hormones travel to the bloodstream and stimulate milk production and milk ejection. The general benefits of this process, I think, are well known. Superior nutritional content for the infant, immunological protection for the infant, and this is the unique component of human milk. No formula contains anything that provides an immunological benefit for the baby. Improved cognitive outcomes for the infant. We're talking a roughly 9-point difference in the IQ of a breastfed baby versus a formula-fed infant. Protection from premenopausal breast cancer and epithelial ovarian cancer for the mother, and improved mother-infant bond. You can't prop a breast and walk away from it. It requires tactile stimulation to the infant. We get eye contact. Additionally, those mothers who are not able to hold their babies can do bonding because they can provide a unique substance in their milk that helps the development physically, immunologically, mentally for their infants. The AAP policy statement is very clear about our role, our meaning physician's role, in getting parents to consider human milk feeding for their infants. It lists the benefits of breastfeeding, gives guidance for initiation and maintenance of breastfeeding for healthcare professionals, and it talks about hospital and community advocacy. It is clear in that statement that breastfeeding and human milk are the normative standards for infant feeding and nutrition. And when we look at all of the long-term and short-term medical and neurodevelopmental advantages of breastfeeding, we recognize that this is particularly important for preterm infants. And we want parents to understand that it is a health issue, not a lifestyle choice to breastfeed. Human milk is the preferred feeding for all infants, including preterm and sick newborns, and there are very few exceptions to that rule. Direct breastfeeding is best, but expressed breast milk, when fortified for premature infants, is the next best. And we say when fortified because preterm infants' human milk is higher in protein, calcium, phosphorus in those first 10 to 14 days after the birth of the preterm, irrespective of the gestational age. However, that milk is going to mature after that 10 to 14 day period to a term product. And it doesn't matter if it was a 26-week or a 24-weeker that was delivered, that milk is going to change, and that's why fortification becomes an important component for us. We do want all babies weighing less than 1,500 grams to receive their own mother's milk. And one of the reasons for that is that less than 1,500 grams has an increased risk for all of the complications of prematurity: retinopathy of prematurity, respiratory distress, increased risk for infection, and of course, the harbinger of danger for the preterm infant, necrotitis and enterocolitis. Studies have shown us clearly that infants who receive formula instead of human milk are 6 to 10 times at greater risk for necrotitis and enterocolitis than their formula fed, than their breastfed cohorts. And we see that in particular in infants who are less than 1,500 grams. So we're talking about exclusive human milk for babies less than 1,500 grams. Pasteurized donor human milk, appropriately fortified, can be used if mother's own milk is not available or the use is contraindicated due to either medications or diseases that she may have. So we want them to get their own mother's milk and also to fortify that milk with a human milk fortifier, and they do exist. And we recommend their use for infants that are less than 1,500 grams. The methods and protocols for mechanical expression should be available to mothers who have delivered a preterm infant so that they can indeed do exclusive human milk production, because that is the best in terms of the baby of the mother. It also is more economical for the parents as well as for the institution, because right now there's no clear place where insurances necessarily have to cover bank breast milk. The neonatal intensive care unit should possess evidence-based protocols for the collection, storage, and labeling of human milk, and we're going to come back to that shortly near the end of our talk. Our unit should also prevent the misadministration of human milk. And most important, there's no data to support routinely culturing human milk for bacterial or other organisms. Many units often will culture milk and separate it, and it gets kept from the infant's use, and there's no indication for that when it's been properly stored. We know that human milk will not sustain bacterial growth. Refrigerated human milk, studies done where we inoculate the milk daily with bacterial cultures, and it does not sustain growth until we get to about the 5th day, honestly, in refrigerated milk. But most instances, we're going to tell people not to keep the milk in the refrigerator more than 3 days. If they think they're going to need it longer than that or later than that, to freeze that product. But we'll come back to that near the end again when we talk about storage of this precious product. So what exactly does human milk prevent? And we like for physicians to talk about the risk of not being breastfed. People just kind of inherently know that human milk is a great milk. It's a great product. It's like apple pie in baseball. Everybody loves it. Anybody can do it. And yet we find that people don't understand the risk of not having been breastfed. And so that's the way it should be looked at by practitioners as well as parents. So you have an increased risk for acute ear infection, otitis media, 100% excess risk, 47% excess risk for eczema, 178% risk for diarrhea and vomiting, 257% excess risk for hospitalization for lower respiratory tract diseases in the first year. For asthma with a family history, 67%, without a family history, 35%. Increased risk of childhood obesity, and that is an entirely different lecture which people need to hear. Increased risk for type 2 diabetes, 64%. The leukemias of acute lymphocytic leukemia and myelogous leukemia, increased risk of 23% and 18% respectively. And increased risk for sudden infant death, 56%. Again, to the preterm, you have 138% excess risk for necrotitis and enterocolitis, and that's no small thing when we consider that we've kind of conquered the respiratory distress issues with antenatal steroids and postnatal surfactant. When we remove RDS, then nutrition and NEC rise to the top as increased risk for morbidity and mortality in those infants. For moms, increased risk for breast cancer, that's epithelial ovarian, breast cancer, that's premenopausal, primarily 4%, and ovarian cancer, that's epithelial ovarian cancer, excess risk of 27%. And you can get this listing as well as other explanations in the Surgeon General's Call to Action that was published in 2011. Now, how does it do all of this? It's breast milk, snake oil. I mean, it's covering a whole range of diseases we can see there. Well, one process that is used as an explanation is when we look at what we call the enteromammary pathway. And that pathway really it's pretty straightforward. You can see the mother will take in or be exposed to a pathogen or an antigen. It comes into her system, she swallows it, it migrates down to activate cells in the Peyer's patches in the gut. That informs plasma cells, white cells, leukocytes, lymphocytes to migrate into the thoracic duct. They go into the breast. Not only will we have plasma cells that will produce antibodies, they secrete that antibody largely in the form of Secretory IgA into the milk. And so you have an update that goes along with the mother constantly, informing the baby of the risk that he or she may be at. How does it work? Well, immunology, you know, we've divided it up into humoral and cellular, as well as anti-inflammatory features. This is how breast milk does this process. The immunological component, I'm going to detail in just a minute, but I don't want to leave out our long-chain polyunsaturated fatty acids, particularly the omega-6 and 3s. Largely for that very first line, it suppresses the production of pro-inflammatory cytokines so that you are able to fight an infectious process without triggering the inflammatory process. And we know that actually sometimes the inflammatory process in infection can do more to the organism in terms of low pressure, low blood pressures, volume loss, than the infection itself. So it is no small thing that human milk protects without triggering an inflammatory response. And some of that inflammatory response process is thought to be one of the reasons why human milk is also associated with decreasing long-term chronic illnesses. We regulate functions of several neurotransmitters. Those fatty acids also enhance your insulin receptors in the brain and other tissues. Some of that is also the reason it informs systems and decreases the risk of type 2 diabetes in infants who are breastfed and decrease insulin resistance. Well, these immunological components that we will go through share certain features. One, they are common to mucosal sites. That's all the sites. That's the nares, oropharynx, the GI tract. They're resistant to digestive enzymes, so that means they persist throughout the gastrointestinal tract. They work synergistically to kill bacterial pathogens. They also work synergistically in an anti-inflammatory process. And that's one of the reasons it's been very difficult for formula companies to try to recreate what is done from an immunological standpoint. All of the products that are in the milk, if they were added to a formulation, would increase the osmolarity of that formulation to a point that it would not be ingestible. And yet they all do exist and work synergistically in human milk. The protection is achieved without triggering inflammatory reactions. And very important, the secretion of these agents is inversely related to the capacity of the recipient infant to produce them at mucosal sites. So that means even our most immature infants will have more of that product. So that breast milk from a preterm mother is an important one, and it moves along with the gestational progression of the baby. So what are some of those immune products? Well, immunoglobulins, and all classes of them are found in human milk. And we know the concentrations of those immunoglobulins are highest in colostrum. And that's why many of us who do promote breastfeeding to mothers will take 1 day, 2 days, 3 days. If colostrum is all we're going to get out of that mom is still important for us, you can see that the volume of colostrum increases as the day goes on, the days go on. So even though it appears that there's a drop in concentration, you actually have the same amount of antibody available because you still have increasing volume. That antibody informs the human system from a molecular standpoint, increasing activity of white cells as well as killing capacity, and it allows the infant to make what we call idiotypic antibodies in respect to what has been presented to it. So it enhances the infant's ability to respond to an antigen or a pathogen. So the immunoglobulins are a huge factor, but I will come back to them discreetly in a moment. I want to talk a little bit about these listed bifidus, these listed humoral factors, many of which are glycoproteins. The bifidus factor enhances the growth of Lactobacillus bifidus, or Bifidus bifidum as it's been renamed. And that means that this is largely the pathogen, or I should say largely the bacteria that populates the gut of the breastfed infant. It's a friendly bacteria, so we know already that it is talking to the infant's gut and therefore informs the gastrointestinal biome, which is a huge big thing today. Who knew the prebiotics that human milk already has that enhances the GI tract would become such a big deal in medicine today? But it was already a process that was unique and there for human beings. It took us a little while to find out about it, but more importantly, human milk helps determine that kind of gut flora that is best for the infant. Resistance factor is a product that got named that because infants, when we started having babies in hospitals and warehousing them there, if you remember the history of that, we had a lot of infants that died from staphylococcus sepsis because of the poor hand washing and hygiene pieces. But they found that babies who were being breastfed didn't succumb to that type of disease and death. And so they called it resistance factor without really knowing what caused that phenomena in breastfed babies. We now know that that is a heat-stable, acid-stable, so it's a product that persists throughout the GI tract that is focused on the gram-positive, particularly the staphylococcus. And so it was something unique in human milk that helped produce resistance for those babies. Lysozyme is produced by your cells, your white cells. It is bactericidal. Lactoferrin is a glycoprotein that's well known to hold on to iron. It makes it more bioavailable to the infant, but equally as important, it takes iron out of the environment so that pathogenic bacteria cannot use the iron for their purposes of production. Now, lactoferrin is also, it's very abundant in colostrum, so that even if I don't get that milk for the rest of that baby's life, if we can get that first colostrum in those first days, it still is informing that immune system. Those bacteria largely are gram-negatives, but some of the gram-positives as well, Escherichia coli, Salmonella, Shigella, Listeria monocytogenes, the Streptococcus species, your cholera species, Legionella, Bacillus subtilis, all of those lactoferrin is bacteriostatic for. Further research on this product has found that there is an innate antibacterial, antiviral, antifungal, and antiprotozoan aspect to lactoferrin that seems to be independent of its ability to do iron chelation. And it does its business then by disrupting bacterial cell membranes, or in the case of viruses, blocking the cell-virus interaction, so that we see lactoferrin important in addressing infections with rotavirus, herpes simplex, cytomegalovirus, hepatitis virus, human papillomavirus, adenovirus, in addition to Candida, Amoeba histolytica, and Trichomonas. Interferon has its full effect that it has in the human being in human milk. So it has its antiviral components there. Complement can be brought in to assist in the destruction of organisms that are negative to the baby. Your B12 binding protein, again, this is a protein that takes B12 out of the environment for those bacteria that need it for their growth. And then oligosaccharide analogs are a very unique glycoprotein that sits and looks like a receptor site for some very pathogenic bacteria. In particular, one is the Streptococcus strep pneumonia. That bacteria attaches to that receptor or a parent receptor and then gets flushed out of through the GI tract, having been fooled to attach there. The cellular factors that go along with just these products that I've enumerated, and there are many more, are also live tissue. Epithelial cells are there, macrophages, lymphocytes, neutrophils. They are completely active. You know that human milk is a living tissue. It contains about 4,000 cells per cubic millimeter, including all of those that I've listed. And these cells are concentrated in colostrum, but they continue to be present in transitional and mature milk. Those neutrophils help prevent infection of the breast tissue, and the macrophages and lymphocytes are actively involved in providing immunoprotection for the newborn and the young infant. Your macrophages secrete that lysozyme that we talked about, and that kills bacteria, and the macrophages are active in phagocytosis. So you can see when we trigger that maternal enteromammary pathway that we referred to previously, it brings a lot of components, both T, B cells, as well as immunoglobulin, into the system for the baby to react with. That lymphoid tissue that's located in the maternal gut and the bronchial system brings those sensitized ingested material to the mother, and it comes in contact with that mucosal surface that she has. It informs those lymphoblasts, and they transgress into the lymphatic system, bringing a host of products that help to protect the infant. Now, Secretory IgA, I wanted to come back to it separately. We know it is an immunoglobulin, and for those of us who may have forgotten, those antibodies immunoglobulins function in very distinct ways. They bind antigens. They can also effectively coat the surface of a pathogen that allows other organisms or other cells to either ingest or destroy that pathogen. They also can mark a pathogen through the process of opsonization so that other cells can neutralize it. So immunoglobulins are very, very important, and the IgA in particular has a twofold process. You would note that we are talking about secretory IgA as the predominant immunoglobulin in human milk. And it's a unique situation because it serves as the first line of defense in protecting the intestinal epithelium from enteric toxins and pathogenic microorganisms. It does that by doing a process we call immune exclusion that promotes the clearance of antigens and pathogenic microorganisms from the intestinal lumen by blocking their access to epithelial receptors, entrapping them in mucus, and facilitating their removal by peristaltic and mucociliary activities. Now, when you consider that IgA, secretory IgA, really has no presence that's very well detected in infants who are less than 6 months of age, then it lets us know that that secretory IgA is supposed to be provided by mother's milk. It is abundant there. And let's look at the microbial pathogens that it is geared against. Viruses, that's rotavirus, respiratory syncytial virus, polio, some other enteroviruses, influenza virus, cytomegalovirus, and if the mother has seen the human immunodeficiency virus, she will also have secretory IgA antibodies against it. The bacterial toxins that secretory IgA antibodies are garnered against are E. coli, Shigella, Campylobacter. And you know, Campylobacter jejuni is one of the major causes for food poisoning in the world. H. influenza, Streptococcus pneumonia, Clostridia difficile, Clostridia botulinum, and Klebsiella pneumonia. It also has activity against Giardia and Candida albicans. So some of these components then require that the mother maybe have seen these in some form or fashion in order to produce those antibodies. But the far more, I think, interesting component of human milk is the presence of substances that don't require that immunoglobulin process. As we said, immunoglobulins are there. IgA, IgM particularly are high, especially IgA. They drop as the days go forward, but as the mammary secretion of volume increases, you get a constant presence of immunoglobulin in human milk throughout the period of lactation. But these non-immunoglobulin anti-pathogens, these do not require the mother to have ever seen these organisms. They exist, their process of protection exists in spite of whether the mom has ever been exposed to any of these. Gangliosides are a glycoprotein. Glycoproteins are huge in human milk, and as we have improved gas chromatography and methods to really determine what these products look like, these molecules look like, it becomes more and more fascinating and awe-inspiring to know that these things exist in the milk of human beings. So if I'm just listing a few of them for your consideration. So gangliosides, GM, then there are multiple numbers of the GM1, 2, 3, but ganglioside overall, it looks at and embarrasses cholera toxin. It doesn't allow it to attach to gastrointestinal cells or brain cells. The label toxin of E. coli, the toxin of Clostridium, Campylobacter jejuni, none of those toxins can adhere in the face of the ganglioside. And as I had alluded to before, Campylobacter jejuni is a worldwide bacteria that's responsible for a lot of GI upset, as well as it can be invasive in pancreatitis, gastritis, and it makes sense that it's here in the milk of the human being. The glycoprotein, which is in the mucin component of human milk, that inhibits rotavirus, keeps the babies. This is why breastfed babies have less rotavirus diarrhea, nausea, and vomiting, as we talked about in that first disease process slide, that is ameliorated by the presence of being breastfed. This glycoprotein that's in the glycosamine glycan against HIV is a unique product. You see that before we didn't know what human immunodeficiency virus was, so no one knew to look for it. The process, though, that is used is that the glycoprotein interferes with the attachment of the virus to the CD4 receptor site. And when we consider what the CD4 receptor site does, what that CD4 cell is responsible for current and past immunity, it makes exquisite sense that this product is in human milk. It is essential to the survival of the human being. So anything that would attach the CD4 receptor site of the T cell, the body knows, the immune system knows that it would be devastating to the developing human. And so here it is in human milk any mother's milk. She does not have to have seen HIV for this product to exist in her milk. Your large molecule against RSV, we spend over $600 a month per injection for protection against RSV for our preterm babies. And a lot of that protection could be provided or enhanced in human milk. Global trials, your GB3 is against your Shigella toxin 1 and the Shigella-like toxin of E. coli. Some more of these non-immunoglobulin anti-pathogens are fatty acids that are in human milk that attach to the envelope of viruses and decrease their ability to penetrate. The oligosaccharides I spoke to before, not only the Streptococcus pneumonia, but H. influenza and enteropathogenic E. coli are also fooled by that process of the oligosaccharide looking like a receptor where they can attach. Mucin, which is throughout the milk, embarrasses your E. coli, your S-fibrillated E. coli. This is a very virulent E. coli, and the fibrillae on the E. coli helps it penetrate and give you total body sepsis with meningitis. And so that mucin component keeps that attachment from occurring. And then your glucosylated oligosaccharides also decrease or embarrass the adherence of Campylobacter jejuni, as well as the stable toxin of E. coli. Babies have problems with gram-negative organisms because many of them require opsonization in order for you to get rid of them, or at least for our natural killer cells and our white cells to attack them. And so there has to be added components given to the newborn and young child to address these organisms. And when you consider that most infants are born vaginally, nose in the rectum, they get populated by their mother's bacteria. And so it makes sense that you have a whole conglomeration of immune processes that address your gram-negatives so that that helps the infant, but also addresses a lot of the environment that the baby is going to see in the future that can be detrimental to him. And it addresses it in a manner that does not trigger the inflammatory response. We come back to that again. When you look through human milk, there are a paucity of initiators and mediators that start an immune process. They don't really exist in the milk. Many of the products that we talked about, lactoferrin, lysozyme, those products, the mucin, the glycoproteins, have dual roles, probably more than just the pathogen and the anti-inflammatory. We're also finding out their neurotransmitter and developmental roles, but that's a different discussion. But their anti-inflammatory components to those make them especially important, not just in attacking the pathogen, but also in minimizing an inflammatory response to that, so that the infant is not succumbing to fevers, etc., because of while they are killing those organisms. The special features of leukocytes we've spoken to, really they are live. That's live, a living tissue, and all of those white cells possess capability to carry out their roles that exist when they are in serum. So how do we protect this exquisite product? What do we do to help parents who may not be able to do the optimal, which would be to breastfeed the baby anytime the baby is ready to feed, until such time as they are no longer breastfeeding? We have mothers have to go back to work. We have mothers get separated from their infants for illness. How do we help them to do this? This is the Academy of Breastfeeding Medicine's clinical protocol number 8, talking about the human milk storage. This one is for home storage for use for full-term infants. Of course, you want parents to wash their hands thoroughly. We never take for granted that they're going to do that. We should always say it, that they don't need to wash their nipples before expressing milk. This is something that needs to go clearly into parents and practitioners' heads. A bath or wipe once a day is sufficient. You don't need to do anything special washing in the nipples. The containers don't have to be Any extra sterilization, if you wash in hot soapy water and you rinse it, that is sufficient. If there's no soap, you will need to boil that water. Glass actually is the best product, although propylene plastics or plastic bags can do the job. You want to be sure that those plastics do not contain bisphenol A. Your glass and your propylene plastics have the least lipid adherence and cell death. So we don't want the lipid layers to adhere to the container. They have, as you now know, many products in them that are important to the immune life for the baby. Overall, a glass container is the least destructive, but we're in basically a plastic world, and we do have concerns about glass dropping and breaking. But be it known that glass is your least destructive container. You can put that milk and safely refrigerate it for 72 hours with a little change. Anything we do other than refrigeration is going to change the product. So freezing it eliminates your cellular activity. It can reduce some vitamins. Most of your protein products, though, are preserved with freezing. However, it's when we warm it back up that we have to be careful. Boiling the milk will destroy lipase. It reduces the effect of your immunoglobulin and both your IgA and the secretory IgA. However, it doesn't eliminate it. So you still have a product that's better than any kind of formula, even when it has been frozen and then warmed up. You don't want it boiled, however. We do with pasteurization is going to be a little more significant than just rewarming milk at home under warm water running from the faucet. But we keep that in mind, that we want to still produce a product or have a product that is usable for the infant, and even in its reduced capacity, it has more immunological ability than formula, commercial formulas. So the nutrient value of human milk is essentially unchanged with freezing and rewarming, but the immunological properties are reduced. And so how we store and how we rewarm are important. Just to have a sense of what maximum recommended duration of that product is. Room temperature, moms that are not able to freeze or put their milk in a frozen refrigerator at work, if there's a constant temperature, it's still good in room temp for 3 to 4 hours. That's optimal. If you have a very cool room, it may be able to stay out there 6 to 8. Refrigerated product, as you see here, 72 hours is optimal. Freezer, 6 months is optimal, but you can still use the product if it is frozen up to 12 months. So moms that cannot pump at work, or who must stop their pumping for whatever reason as the child gets older, can pump up a supply and still have it for the baby to use later on. These are the reasons we recommend exclusive breastfeeding for infants, both term and preterm. There is continuing evidence of the benefits for infant survival, growth, and development. We know that it provides all the energy and nutrients that an infant needs during the first 6 months. So we say exclusive human milk for the first 6 months is the optimal exposure that an infant needs, and then to continue with appropriate supplemental feeding of complementary foods, and continue with human milk feeding until such time as mother and infant decide that it should no longer occur. We know today that that question about, well, is it really making a difference for the baby after a year? Yes, it is still making a difference, because that mother-infant environment is still being brought to the infant. Mom's workplace, mom at home, her immune system is still more mature than an infant, and it can respond to bacteria and viruses in a rapid manner and educate her milk quickly as a product to protect her infant. So Exclusive human milk also reduces infant death caused by common childhood illnesses. What precludes mom from breastfeeding? We say psychosis, and just a comment that there is only one thing that is better than mother's milk, and that is mother's love. And so her ability to be available for that infant is most important. So if we have a mother who has a diagnosis and the medication that she is on is contraindicated for breastfeeding, then so be it. We are not going to play with her antipsychotics in order to give her a breastfeeding opportunity. It's much more important that she be available to that baby, both mentally, spiritually, and physically. And I guess that would be a promo for breast milk banks, because if we had them, then that baby could still get human milk and have his mother's attention. There are other conditions that preclude breastfeeding. Bipolar disease, control on lithium. It's not that we cannot monitor lithium. You're looking at the thyroid status of those infants who are exposed to lithium. It is the disease process of bipolar itself. A lot of times those patients are simply not reliable, and you don't want to take that risk that they are taking meds and not bringing the baby to you, or not taking meds or taking too much, so that is still one that we consider that precludes breastfeeding. Active TB, basically treat the TB, and once you do that, everybody can breastfeed. And then in this country, HIV infection. Other parts of the world, it's a death sentence to be feeding formula and mixing it with dirty water and contaminated water. But do caution you, though, here in the United States, we are seeing mothers who are HIV infected, whose viral loads put them as undetectable. And some of them are doing breastfeeding, even though they've been informed differently. And so there are studies that will be following those babies and mothers as time goes forward. Drugs that are contraindicated during breastfeeding: bromocriptine, cocaine, of course, PCP, primarily because it is a lipophilic drug. You will actually get more PCP in the breast milk than is in mother's serum. So we particularly do not want moms who use that drug to breastfeed their baby. The others are your anti-metabolites that are listed there, and you would know to look up any other drugs before you absolutely decide that they can't be used. A great reference is ToxNet with the NIH that has LactNet under it. I refer to ToxNet because there are other things that pregnant women and lactating women may come in contact with besides drugs, and ToxNet is a good reference. But LactMed under ToxNet gives you an updated, clear picture of the different medications that are out here that moms who are breastfeeding could be exposed to. And before we assume that they are contraindicated, you should always look those up. So where are we then? Breastfeeding is all in one. It's psychoneurologic stimulation, because you're looking at the baby. All the tests that we've done that show that contact is important is right there in front of our faces when babies are breastfed and held. It's food, it's hormones, and it's the immune stimulation modulation. When the baby receives mom's milk, those components inform the baby's natural killer cells, monocytes, leukocytes, as well as providing passive immunity. That stimulation of those natural killer cells, monocytes, leukocytes, macrophages, enhance the ability of those systems to respond to antigens and pathogen presentation. And that includes antigens that we present to them for immunization. So that a breastfed baby has a much more robust response to being immunized, and for point by point is better covered and protected from that immunization than their formula-fed cohort. So that immune stimulation, we sometimes call human milk the first immunization, prepares the immune system of the infant to respond to immune challenges as they grow older. It provides, as we said, granulocytes, live working cells, and it's medication in many ways, not just the comfort of being held, not just the glucose source or fat source that we know that satiety and feeding brings the infant, but also the medication in your passive immunity and many non-immunoglobulin components that are in human milk to help heal and keep healthy newborns. How long to feed? We spoke to this a little bit, 6 months of life exclusively, and then solid, and as long as mother and baby mutually desire. So human milk feeding is the preferred feeding for almost all infants. I think when you realize the immunologic component that comes with breastfeeding, it is light years away from any formula product. It makes formula feeding a very distant second as a choice for the optimal outcome of humans. Supplementation is rarely indicated, and we know it interferes with successful lactation, so we want moms to do their best to exclusively breastfeed. We want to be, as healthcare providers, actively supporting and promoting in our communities and our society mothers to breastfeed. And we want moms to feel comfortable continuing breastfeeding as long as desired. It's absolutely necessary for Americans to recognize that affordable and attainable health care begins with breastfeeding. We are still one of the worst breastfeeding of the developed countries, and we need to put our foot forward for the health of our infants. Deciding to breastfeed is not just a choice, it is truly a healthcare decision. When you look at all of the illness, the ear infections, the asthma, the GI upset, the diarrhea, the lower respiratory disease tract, all of those things are pictured and around secretory IgA, the lack of it, and those non-immunoglobulin components that help prevent those diseases. It is a healthcare decision, and moms and healthcare professionals need to be aware of it. Breastfeeding is a species-specific, continual immunological update between the environment and the infant, and it is the single intervention that confers a lifetime of health benefits in infancy and beyond. So there is no time that human milk is not important for the growing infant. We want to emphasize those first 6 months, the next 6 months with complementary feeds, and as long as mother and infant so desire, and let them know that it is always important that mother's immune system is always updating the milk supply that is given to her infant. I thank you for your attention, and I'll take any questions you may have.
Thank you so much, Dr. Young. That was a wonderful presentation. And at this point, we'd like to open it up for questions to the group, and you can just type the questions into the chat box, and those questions will be assigned to you, Dr. Young, so you can please read the question and then respond to it as you see fit.
They need to put the questions in the questions box.
In the questions box. And I have one question just to get us started while folks are typing in their questions. Dr. Young, we're interested here in what statements and other persuasive methods have you used to encourage mothers of premature infants to breastfeed? Or to pump their milk, excuse me.
It's interesting that many times that they realize that the baby is vulnerable. They recognize it, and even though I've had mothers who didn't breastfeed a single full-term infant, but who agree that this particular baby, because he's premature, needs her milk. So a lot of times it's just our saying, I'm expecting you to provide human milk for this baby. This baby is very, very vulnerable. He's small, his gut's not mature, and your milk is made exquisitely for that baby, and it has products in it that are extra protein. And I actually explained to them that preterm mother's milk is different from term milk, and that none of our preterm formulas that we have do that job, especially the immune job, and that even those preterm formulas were based on looking at preterm mother's milk, and that's how they adjusted it. But the big thing that they could not add was the immune protection from infections, diarrhea, and parents understand that. I've had some people that I would never have even thought would pump milk for us do so. That they warn me as soon as the baby goes home, I'm not going to give any more milk. Some of them have stuck to that word, that as soon as the baby went home they went to formula, but some of them have surprised themselves and continued to breastfeed their baby. So I just simply tell them the truth.
Dr. Young, if you pull out your questions, I've assigned a question for you. There's a question on the floor.
What mechanisms do you recommend to promote breastfeeding in communities where the rates of breastfeeding are very low? Oh, I get this question all the time. You have to keep telling people that human milk is the best milk. And it's the problem with communities where rates of breastfeeding are low is that that message is not given all the time. It needs to be given from the first day of prenatal care all the way through to the time they present for delivery. And if they didn't get any prenatal care, you still have to give that message, and you have to give it unequivocally. Here at Howard, we actually have them sign a form that we have to get their permission to formula feed their infant. And there's some looks, we get some very interesting looks when we ask for that, but we put on that form some specific things that human milk does, that it protects the babies from ear infections and colds and pneumonia, that it decreases their risk for diarrhea and nausea and vomiting, and that it decreases their risk for sudden infant death. And that particular item is one that's very sobering to those mothers, because too many of them know women who have lost their babies to sudden infant death. And so I find that even though I have moms who will sign it, many of them will go on to try to breastfeed anyway. There is a fear that they will not have enough milk. That's their concern many times. And so it is incumbent on us to be sure moms put babies to breast in the hospital and do their best to get that volume going, so that when they get home on that they go home on that 48-hour, that's problematic for your vaginal deliveries. But if they've been putting that baby to breast, they're going to have a milk volume that may surprise them when they get home that evening, and they're just much more likely to breastfeed, or even combination feed is better than formula feeding alone. But yes, we ask mothers to sign permission for us to formula feed their babies. It allows us to give that conversation to them, to go back over things they may or may not have heard. But specifically, I ask my nursing staff and physician staff to read. I do not assume literacy. They have to read that consent form to the patient, and then they sign. That's how we're trying to address it. And we've moved from around 22% breastfeeding initiation to now we're almost close to 70% initiation at Howard now.
Thank you, Dr. Young. Are there any other questions?
There are no other questions at this time.
Well, thank you so much to Dr. Young, and we also want to thank you that joined us for this presentation, and we hope that you'll be able to join us for other presentations in this webinar series. Have a great day.
Okay, thanks.